Hi everybody, welcome to the healthcare.ai broadcast, hands-on machine learning. So I'd like to introduce Spencer Nickel. Spencer, thanks for joining us. A little bit about yourself?
Yeah, my name's Spencer Nickel. I've been with Health Catalyst for about almost 5 years now.
Whoa,
It's been
old hand.
yeah, I've been here for a little while, and a lot of my work has been in patient safety. So we've worked with a couple different clients, including IU Health around infection prevention and patient safety.
Very cool. We're excited to get in that a lot today. Thanks for joining us. Shufang, thank you for joining us.
Hi, Shufang Xi here. I studied data science and image processing during my PhD at Arizona State. And after my graduation, I come here.
Perfect.
Yeah.
Thanks for joining us. So are these Utah summers hot enough for you?
Not as hot as Phoenix.
So is that a good thing or?
It's pretty good.
I'm glad to have you. We have Kristen Kelley on the phone, Head of Infection Prevention at Indiana University Health. Kristen, thanks for joining.
Hi, glad to be here.
Perfect. So we'll get into a chat here with Kristen just in a minute. For those of you joining on YouTube, please log into your YouTube account so you can chat with us during. We're excited to get questions from you for Kristen. And subscribe to the channel, subscribe to healthcare.ai so you can get the blog posts, get updates as to what broadcasts are coming up. And we just want to remind, we're going to have folks coming into Salt Lake City in September for Healthcare Analytics Summit and 2-day training in terms of machine learning and R. So please check that out, Google Healthcare Analytics Summit. And we're excited to get started. So might as well get into the meat of the interview today. So we're talking about CLABSI, and CLABSI, I'm not an expert, so I'll just try to give high level and then we'll go into the details, but it's a central line associated bloodstream infection, and it's a menace to healthcare, and we're going to talk a little bit about what people are doing to try to combat it. Kristen, first off, we're excited to get to know you a little bit. How did you end up at IU, or Indiana University Health, and where did you come from? Where did you grow up?
Oh, okay. Well, I am originally from Boston, Massachusetts, born and raised there. I am a Hoosier by marriage. So my husband is from Indianapolis. So I have lived here for well over 10 years. I've been at IU Health for a little over 15 years, and it's been just a wonderful place to work. I am currently the Director of Infection Prevention for the Adult Academic Health Center. And yeah, I'm glad to be here today talking to you all.
No, it's a really exciting position there with so much going on around hospital-acquired infections across healthcare these days. So talk to us a little bit about Indiana University Health. One of the bigger health systems in the Midwest, academic center, and you reside at the main hospital then?
Yes, so we're in downtown Indianapolis. We're really lucky. IU Health is a system of hospitals that basically span from the northern part of the state to the southern part of the state, all the way east and all the way west. I think we're a 17 hospital system, and we are, they like to call us the flagship, so we're right in the center of all the activity in downtown Indianapolis. And we are 2 hospitals that are have merged into one academic health center.
And what were
It
those
is
two
a
hospitals?
pretty busy, level 1 trauma center, cancer, tertiary referral center. We pretty much do it all here.
Beautiful. And the 2 hospitals that are merging, was that Methodist and IU Hospital?
Methodist and University.
Mm-hmm. Perfect. Talk to us a little bit about how do such large health systems focus on particular initiatives? So obviously you spend your time in infection prevention. How do executives or these teams say, okay, we want to focus on CLABSI, for example?
Yeah, sure, that's a good question. So our leadership here, the way they went about it was, I think, just very admirable. We looked at the data to show exactly where the harm events were coming from and exactly where patient harm was occurring from the data that we had at the time. And then I know our system executives also talked with the system CMOs and CNOs from across the state to really talk to them about the harm events that they felt were most pressing and most important to focus on. And they surveyed them and really had some discussions. From those conversations, in conjunction with the data, they decided to land on a good select number of metrics to track and trend to really impact patient harm and to ensure that the patients that are coming through IU Health are kept the safest that they can be and delivered the highest quality of care.
Beautiful. So you went to the data.
Yeah.
We love hearing that. And you found that CLABSI, talk to us a little bit about what you found. So high mortality rate, it was a huge cost driver. And maybe
so
walk us through,
CLABSI,
just what happens in a typical CLABSI case even.
Sure. Well, CLABSI, is one of the metrics that is high on the radar with the Affordable Care Act. It is a harm event that has been tracked by the Centers for Medicaid and Medicare Services division with their reimbursement. So they, for many years, have tracked CLABSIs in the CMS population. Now it is part of the mandatory reporting that is required underneath the Affordable Care Act. This program is also executed by NHSN, a division of the CDC. So this is a big national priority. It's also the priority that our system executives saw as an opportunity to make patient care safer at IU Health. A CLABSI is short for central line associated bloodstream infection. So a central line, which is sometimes referred to as a central venous catheter, it's essentially a tube that doctors put in a large vein, either in the neck, the chest, the groin, and typically they infuse medications or fluids through a patient. So, for example, if my mother had surgery, she got a central line during her surgery to help infuse the anesthesia through her, also to make sure that she stayed very well hydrated. So they're a very important aspect or medical device for patient care. Unfortunately, though, because that device, goes through the patient's skin, enters into a vein, and then can essentially be put all the way through to the top part of someone's heart, that tube is inside of a person, and it is, connected to those veins and the bloodstream that keeps, patients alive. So sometimes bacteria can infect these central lines, either through the insertion sites or through the care of them. And the typical way that it will happen oftentimes is through breaches in that care. So that could be touching a central line with someone's hands, or it could be, a central line dressing that's placed on top of the line to help keep it secure and safe, came undone. So nationally, there are a set of guidelines and a lot of great data and studies that help guide hospitals how to prevent these CLABSIs. Some of those top things are, performing hand hygiene, making sure that, the healthcare provider that's putting in the central line has sterile gloves, a gown, a cap, and a mask on to prevent their bacteria from landing on the line when it's inserted, or ensuring that, nurses scrub the end of the central line with alcohol to disinfect it prior to infusing any medication. So those are a few of the interventions. Sometimes what we've done in the literature is they've bundled those interventions into, a handful of, 5 or so things and calls it a bundle of care. So those bundles are something that we track and trend on the hospital level.
Interesting. So bundles of care, and that's being reported to the CDC. You said the Affordable Care Act is monitoring how hospitals are doing in terms of that, as well as CLABSI rates. So
Yeah, so we report the number of CLABSIs that we have, as well as every other hospital across the country monthly. So every month we will put that into the government database for tracking and trending, and then quarterly they will, sync up that data. So we make sure every quarter to do one last double check before, it goes into the portal with the lock and key.
fascinating. So a huge national concern around these infections. And for a typical patient that has a CLABSI, what results, what do you see for a patient like that?
So sure, the CDC estimates that there are around 80,000 new CLABSI infections in the U.S. every year, and that can cause about a 12 to 25% increased mortality risk for a patient who develops a CLABSI. So, it could have very, very serious, consequences, causing death at the worst case scenario. What it could also cause as far as morbidity is, it could put a patient that's in a medical surgical unit into the ICU. It could also, cause sepsis, so a patient can get very sick from the bacteria that is in their bloodstream.
Interesting. So higher mortality, comorbidities, extended length of stay, higher cost for the health system. Pretty dire infection. So for those of you listening out there and watching, we want to make sure that you're involved. So please send any questions our way. Shufang is monitoring the chat. And so Health Catalyst and IU started working together to address this issue after the team at Indiana University decided it was a priority. Do you mind describing a little bit about how that project started? Let's get Spencer involved here. So Spencer, data architect.
Yep.
What's your view from 2 years ago or however long it's been? How did this start up?
Well, I mean, so for one, I'm a data architect. I'm not a clinician, and so when I was asked to kind of help out with this project around patient safety, we heavily rely upon people like Kristen to help us understand what the problem is, and then it's my job to look in the EMR and be able to start finding these data elements that are important for a given project. And so we started working with Kristen and her team, who had all of the clinical knowledge and kind of teamed up with me to try to find ways that we can improve care for CLABSI.
Okay, and so you're digging into the data, actually looking at the data as to CLABSI rates by department, and should we go into the visualizations, or what would be a good way to dig into how this works?
Well, I mean, so when we started the project, with CLABSI, the first place that we were, kind of tagged to start with is finding people who have devices. And so, surprisingly, across many hospitals, identifying people who have a central line is not as easy as you would expect, which is why, a lot of hospitals do their device census counts manually, every single day. And so that's where we kind of started, is to kind of let's find people who have devices, integrate all the information that they're submitting to the government, as far as people who have CLABSIs, pulling that information in and being able to start looking at why people got CLABSIs, historically, and hoping to leverage that information to one, get a baseline of where IU was at, but then also working with Kristen to try to prevent CLABSI from happening. And so we kind of developed in conjunction with Kristen, we developed a dashboard in ClickView that helped address, it helped kind of visualize to Kristen and her team as to how they were doing. And So we have a couple slides here. And Kristen, I don't know if you want to add any other commentaries as to, to what your process was like before we started engaging with you,
sure.
and to where you guys were at that point.
Yeah, so if we take a look at the first slide called the unit scoreboard, you can very succinctly see, obviously this data is blinded and made up, but we have a couple categories here. So the columns show all sorts of different unique data points. So we have days since the last CLABSI, utilization of central lines, so it's how many lines we've been using, the maintenance bundle, so we obviously want, you want those numbers higher at about 100%. That means we're doing all the care of the lines the right way, the same way. Percentage of, chlorhexidine bathing, which is another intervention. When we first started this project, one of the things that we really noted was that our processes were very manually taxing. All of those columns were different Excel reports that were lived in different databases and different drives across our department and across our organization. And so you log into one Excel file to look at one thing, you log into another to analyze another aspect, and it just really wasn't showing the total picture. So the first step that we really did with this project was consolidate all of our data sources so that we could really truly accurately analyze the entire picture with all of its complexity. So this was, this dashboard here shows all of the units in running order. We wanted to add the column on the right that showed declining measure count. So if the unit was having some struggles and some of their processes were trending down, we would analyze that to see which units were having some, reductions in process measures so that we in infection prevention, as well as other clinical departments, could intervene and help the units to get back on track. So we know, human nature is highly variable and always fluctuating. Some of these percentages would move and adjust depending on the day. So I think this was an opportunity for us to get ahead of the data and not behind. I would also say that, our processes were largely retrospective. So, a CLABSI case would occur, we would huddle on it, we would try to understand what the root causal factors were, why that case occurred, and then try to take those learnings and extrapolate them to a future event so that we could, potentially prevent cases in the future. But just because one case happened in March doesn't mean that the next case in April is going to have the same risk factors. So when we designed this process, we wanted this to be easy. We really wanted the data to auto-analyze itself. So this dashboard here shows all of the compliance measures if they're going up or down. The next dashboard that we're going to show you, our slide 2 on the unit scoreboard, it really shows what the manager of that unit or that clinical leader could look at when they log in. We wanted it to make it very easy for the clinician to log into their unit and see how they're doing on these process measures, and to really show, how many lines they have in their patients that day. What's their bundle compliance? What's their CHG bathing compliance? And to make it very easy for them to analyze their data in just a couple minutes and then go out to the bedside and have some coaching conversations and really drive to improvement. We wanted our managers to be focused more on the action and not to be taking all of their time in the data analysis piece.
That's a great
And then the
summary.
final step was we wanted to take it a step further by, could we take all this data and mine it in the moment to predict what patients are at the most risk for CLABSI? And that's where we really started the development of the risk prediction.
That's a great summary, Kristen. So lots of components in there that are applicable across healthcare. So when you first started out thinking about CLABSI at IU, you mentioned that the data was kind of scattered all over the place. So Excel files here and there, maybe some databases. And so one of the first steps was using the data warehouse. Just to back up to the high level just for a second, maybe Spencer could speak to that, was just gathering the data together.
Yeah, I mean, as Kristen mentioned, they had for their compliance measures for a lot of the interventions around, their hand hygiene compliance or their bundle compliance. Yet they were kind of capturing that information in different ways, and so I helped, kind of with Kristen's team, kind of build that process of bringing all that information together, and then then it kind of helps you see gaps in where which units potentially are kind of performing or underperforming other departments, and then it became a case of can we push this even further? Can we it's nice to know historically the compliance of a given unit, but it'd be nice to in the moment, as of for those individuals who are in the hospital right now, can we give a list to a unit manager that says you have 15 people in your hospital right now, or in your unit right now, 5 of them are at high risk, 5 of them are at medium risk, and 5 are at low risk, and that's where Kristen really kind of challenged us as as a partner to let's figure out a better way to sort risk of patients who are in our units that don't have CLABSIs yet, but are there. And so that's where we started kind of really digging into the data, as Kristen mentioned. And initially we didn't have any predictive algorithms. We kind of relied upon. I think Kristen found this Joint Commission study that kind of highlighted a suite of a series of variables that make individuals at a higher risk than others. And for example, I think the Joint Commission study said that males are at a higher risk than females, but it didn't tell us how much more at risk were they. It just kind of had some high level variables around different risk factors. And so we tried our best with what we had to leverage that information, and tried to apply some kind of sorting. Obviously someone who's had a device in them for a longer period of time is at a higher risk, and so initially we could leverage that as kind of a way to categorize and rank patients that are in their hospital now.
Yeah, so
people have it longer.
So you assign them a point if they're above a certain age,
Yeah.
if they've had a line for 5 days or what have you.
Yeah.
It's kind of how a lot of the industry does predictive work. Is these kind of assign them a point for this, a point for that, and it makes sense. And that was innovative for where they were at. And then I'm trying to think of how it exactly happened, but we were talking one day and you're describing this project, and I was like, wow, that sounds like perfect for machine learning, which we were getting excited about at that point as a company and myself. And so Spencer and I sat down and started using healthcare AI to get a sense for all these variables that they pulled into the data from the Joint Commission, from the CDC, with this variable set, how likely or how accurately can we predict whether somebody will get a CLABSI today using this variable list? And it was kind of an iterative process. We would work with Kristen and her clinical team there, a few other individuals, even a mathematician I remember, and you got some new variables from this discussion. We'd try the model again and get a little more accurate, and then we'd go back and find some more variables in the EMR. Not always easy to find variables in the EMR. That was kind of your role.
Yeah, that was my role. It just kind of depends on the variable. Sometimes certain factors are discrete elements in the EMR and others aren't. And so we kind of had to use what we could find. And so I think there's probably other variables that we wanted to add, but just based on data availability, we have to be practical and kind of use what we could find.
Yeah, the model turned out to be pretty accurate. We can show a quick performance report here. So after we finished the model, we found that, it was based on 71,000 central line cases, had 23 input variables, tried, and we ended up with 17 variables that stuck in the model. So this is pretty typical, is you don't boil the ocean, but you tried a lot of variables. Some of them help, some of them don't. And we ended up creating predictions for 400 patients each day. And might be a good time to check in. If there are any questions that are pressing there in the chat, we can work them in.
Yeah, there's an interesting question and asking how do we analyze the data and what tools do we use?
Yeah, that's a great question. So on the SQL side,
I mean, on the SQL side, it was strictly SQL, where we'd build some scripts that would leverage those variables and categorize patients in such way, and then we'd surface them in some kind of visualization.
yeah, so we got SQL to do the transformations of the data, the analysis, QlikView to visualize the data, and we used Python to actually do the machine learning, and ended up generating 400 predictions roughly each day. That's a fuzzy number because obviously the people with lines in them each day, that number changes. But Kristen, do you mind talking just a little bit about, now that you had this forward guidance, how does that help?
How does it help prevent the CLABSIs?
Yeah,
Is
so
that what
we
your
showed
question?
that we have this dashboard that was descriptive in the past, and now that we have forward guidance and a probability of a CLABSI for a certain patient, how can that be used to improve care?
Yes, I mean, our thought along these lines has always been that, with the healthcare changes that have been moving forward, consumers want, cheaper care, safer care, and more accessible care. And so really, I think, the next many years is all about using resources very wisely and very shrewdly in a way to reduce costs. So just like anyone else, we're trying to do our jobs, better and smarter, with every day. But we wanted to do this as a way to prioritize, where we focus in on. So again, spending less time analyzing the data and more time in the action mode. The bundles are very clear. The bundles should be done 100% of the time, every patient, every single day. But sometimes you'll have some factors or some patients that have a high number of risk factors. We could sense it when we were on the units, but we really could never put analytics to it. So we would always have a sense that this patient was high risk. They're in the ICU, they've been in the hospital for a long time, they're immunocompromised, they have, cancer, they have, 2 central lines, an art line, and, they're on the ventilator. But we could never really deduce that, this was the one that was likely to get an infection. So what this has really done for our team is help us to focus our resources, just to know where to prioritize. I think it's also been a tool for our clinicians to really see what patients are popping up in the predictability and the probability group. It's a great way to balance the risk versus benefit. This patient's at high risk for CLABSI. They also still have their central line, and to really have, some of these conversations for next steps and what needs to be done. To be honest, we are still at the infancy with this technology, having such a powerful tool as this, and really figuring out, what are all the ways that we can utilize it. We're still in that discovery mode because this is still pretty new for us since we've developed it. But what we have done is we put this in the hands of some of our key clinicians. We've used this as a way for infection prevention to prioritize, the limited resources that we are. And we've also put this in the hands of our, our CLABSI harm team as well. And we're preparing to hopefully put forward a more structured study in the future with this.
That's a fantastic description. So you're finally able to automate the insights and deploy resources according to who's highest at risk for CLABSI. That's fantastic, Kristen. You've been a fantastic partner throughout. I think we've both learned a lot from this project. Where would you see this going from here? I mean, other types of infections or more units or clear guidance as to what we can do to reduce that person's risk?
Yeah, I mean, and the potentials are endless here. I mean, we are putting so much data into the electronic medical record every day that, you know, sometimes it does feel like a black hole, that there's so much inputted and we don't get out as much as we need and as much as we know is in there. So, I mean, I think that this project shows that the potential is great for so many other, you know, infections, harm events, you name it. I know that there is some precedence with mortality and utilizing risk scores. We're definitely going to be developing this and understanding this model more and hope to develop many more in the future. You know, the other potential is total harm, really looking at all harm events instead of just, you know, this type or that type. So it'll be an exciting, you know, next many years ahead to see how we utilize this technology to make care safer for our patients.
Yeah, so many avenues ahead. It just depends on the business priorities there and the clinical priorities. That's fantastic. In terms of how this ended up, what was the result? So clinicians finally had the forward-looking guidance, and that ended up helping. What was the end result?
Well, we're having a great run so far with our CLABSIs. We have really been working hard in many areas, bundle improvements, central line guidelines, reducing central line utilization, using all of the data that's in this dashboard, including the risk prediction model. So we're definitely having a great stretch. We've gotten a 20% reduction last year, and through June of this year, we have an additional 30% reduction and heading in a great direction. So
that's amazing. Congratulations.
Guys,
Very forward-thinking clinician. We appreciate it. So we have some questions in the chat. Shufang, do you want to highlight a couple?
There are not many questions in the chat right now. Just as Jonathan asked if any other models has been used for other kind of infections, and we just covered that. Yeah.
Yeah, so sepsis is one that Health Catalyst has worked on with other clients, and CAUTI is one that we have been talking to certain health systems about, so there's definitely other options. SSI would be fairly similar.
I mean, CAUTI would be super similar, and you could probably leverage a lot of the same variables for CAUTI. And then I guess Kristen could probably say whether or not SSI is kind of similar.
yeah, I think the potential is there for any of these.
Yeah.
It'd be exciting.
Perfect. If there's no other questions, Kristen, this has been fantastic. Thanks so much for joining us.
Thank you so much.
Thank you, Kristen.
Yeah, thank you all. Appreciate you joining. Again, we'll be at the Healthcare Analytics Summit in September, so join for that. 2-day machine learning training in person. Amazing. Kristen Kelley from Indiana University Health, 20% plus reduction in CLABSI due to machine learning. What a fantastic story there. Please send us any questions on Slack. She actually joined the Healthcare.ai Slack group, so you should too, healthcare.ai. Thanks all for joining. Shufang, Spencer, thank you guys.
Thank you.
See you next week. Thank you for joining us today. Remember to like, share, and subscribe, comment below, and click the links below to join our Slack channel and our Healthcare AI community.